Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you so much, and I'm excited to be here. I also just want to say I'm from Spokane, so I love seeing all of the Spokane folks out there. It makes me really, really happy to see such good folks providing HIV care in my hometown. So, okay, I'm going to try to cover some treatment innovations that weren't covered by, I think Jihan already spoke with you all, and then just briefly kind of give a gestalt of some of the ACTG studies that were presented because there were too many to cover very well. So these are my disclosures. None of them are related to this presentation. Okay, so moving right along in, these are kind of rapid fire. Feel free to ask me questions. I'm not going to be presenting a ton of detail just to be able to get through the material. But this study is looking at HIV remission in the Titan trial. For those of you who tuned in to CROI last year, this is a study done by Ole Søgaard and colleagues in Denmark. It's the same group of people and a very similar study design to the eClear study that was presented and published, I believe, in Nature this year. So this is a 2x2 factorial study looking at the effect of two different broadly neutralizing antibodies, or bNAbs, plus Lefitolimod. Lefitolimod is a TLR9 agonist. So the rationale of putting these together, I'm just showing briefly on this slide directly from Dr. Søgaard, is that the TLR agonist helps prime the innate and adaptive immune responses prior to antigen exposure to create presentation to the CD8 cells and boost cytotoxic lymphocyte specific immunity to HIV. And it's also TLR9 agonists are also being used in studies looking at Hep B eradication as well. And then I think we're all more familiar with bNAbs and their use. So as I mentioned, this is a 2x2 factorial randomized design. Pretty tiny study, but it's a pretty intense study. So essentially, people either got placebo or Lefitolimod plus placebo, or placebo plus the two bNAbs, or both interventions. The Lefitolimod was given multiple times, both before the ATI or analytic treatment interruption, and the bNAbs were given once then and once at 6 weeks. The population in this study is done in Denmark, Norway, and Australia. This is mainly white and a few multiracial men, a few women, 40s to 50s. Most of these folks had been living with HIV for quite a while and had been on ART for a median of 11 years, so well-treated people with good immune systems and good suppression of their virus. Everybody to enter the study had to be sensitive to the two bNAbs by a PhenoSense assay, and there were 11 or 12 people in each of the four arms. So again, pretty tiny. So here's the primary results of the study. So we can see these blue arrows are when people are getting the TLR9 agonist, and you can see that, within 2 weeks of coming off of ART for this ATI, everybody rebounded. It took some people longer than others, but everybody's rebounding. If we look at the Lefitolimod arm alone, everybody rebounds. One person then suppresses for a while and kind of bumps up, but everybody else rebounds. In the people who received just the two bNAb infusions, not everybody rebounded. 2 people in this group actually remained off of ART at this point indefinitely. I don't know how long it's been, but I think it's been over a year at the time of presentation. But at least everybody else who did rebounded slower. And then the people that got both interventions, sort of same thing. And overall, a third of the people who received the broadly neutralizing antibodies made it through the entire 24 weeks of the ART interruption without a rebound. So this is just in survival format and comparing the different arms. So you can see that Lefitolimod compared to placebo, again, in the factorial design, so you're combining people who just got Lefitolimod versus placebo, there's no difference. People who got bNAbs versus placebo, there's quite a difference. People who got both interventions, a difference. And then comparing just the bNAbs plus the bNAb plus the TLR9 agonist, there's no difference between those two. The take home for this study is that there's likely both a neutralizing and vaccinal effect of the bNAbs that they showed in a bunch of other kind of mechanistic slides. There are some people who at this point have post-treatment control, not calling it a functional cure yet because it's been too short of a time period, but this looks kind of promising for bigger studies and is actually pretty symmetric to the results of the ECLAIR study that was previously presented that they showed. Those folks in the ECLAIR study were all treated during a primary HIV infection or acute infection. Moving on, another study that has 2 bNAbs and Lenacapavir. So I think Lenacapavir is more familiar because it is FDA approved for people who have multi-drug resistant HIV, 6-monthly injection that's given subcutaneously. And in this study, which was sponsored by Gilead, it's combined with 2 different bNAbs. So these are well-characterized bNAbs, but the Gilead version of these is called LS after it. They're have been structurally changed to be able to be given every 6 months. So it's a longer acting formulation. The drugs are called TAB and ZAB, just to make these names a little bit shorter. And so this study was a little bit truncated because of an issue with the product itself, with the Lenacapavir. Many of you have been probably aware that Lenacapavir was put on a clinical hold during 2021 because there was an issue with the glass vialing. So not with the product at all, but just a concern for like an interaction between the glass vial that it was manufactured in and the drug itself. And so this study originally was going to look at a 2-dose treatment over the course of a year where it was dosed at baseline and dosed at 26 weeks. But because of that inability to give that second dose, what ended up happening was that participants got the first dose, went for 26 weeks, and then converted back to their standard of care ART that they came into the study on. So this study also included adults with HIV who had been suppressed for at least 18 months. They also had to have their virus susceptible to both of the bNAbs at baseline and have good immune function. And so they came in on their standard of care ART, got this 1 6-month dosage of all 3 drugs, and then converted back to their standard of care ART. There were 2 different dosages of one of the bNAbs, but otherwise everybody was treated in this study. So here's the 26-week viral efficacy snapshot. So essentially in both of the 2 groups, again, they're just getting 2 different doses of the ZAB, bNAb. 18 out of 20 participants remained virally suppressed through the whole 26 weeks. 1 person they didn't have data on because they withdrew, and 1 person did have confirmed virologic rebound that then resuppressed quite easily when back on their standard of care ART. Overall, there were no serious adverse events. A couple of injection site reactions and the mild infusion reactions that we've seen with giving monoclonal or broadly neutralizing antibodies, and no significant immunologic changes here. So the take-homes from this study are that 2 bNAbs in combination with Lenacapavir, or capsid inhibitor, that's FDA approved, can maintain virologic suppression for 6 months, minimal safety issues. So this could be under consideration for a twice-yearly all-parenteral regimen. The limitations of this is that it was an extremely small study in phase 1. There's now a phase 2 study underway. And then I think it's really important to note the limitations of this study is that this study was done all in people with clade B virus. And then they screened 124 people, of whom only 55 had virus that met susceptibility. So just in terms of thinking about actually delivering a therapy like this to real people, not everybody's virus will be susceptible. It's a pretty expensive test that's not readily available, this PhenoSense, to be able to determine if their virus is susceptible to it. And then obviously there's running infusions and all of the other things that go along with giving bNAbs right now. Although I think there's probably promise in being able to give bNAbs intramuscularly, but it still would be a parenteral administration. Okay, so the next is an update on Islatravir and the effect of lymphocytes. I thought this was a really great presentation by Kathleen Squires, who's from Merck themselves. And it was sort of giving an overview over the reasons why the FDA put a hold on the clinical development of Islatravir due to concerns of decreased overall lymphocyte counts and CD4 counts, inclusive in people who were receiving Islatravir for pre-exposure prophylaxis, so people not living with HIV. And so she went through a little bit of the mechanisms and some of the data here. So one of the things that they found was that Islatravir triphosphate, the active version of this drug, preferentially accumulates in lymphocytes, which is good in terms of systemic toxicity, but not so good for lymphocyte toxicity. They found no mitochondrial toxicity to other cell lines or other organ systems when they did extensive studies of this. And then these are just kind of snapshots from 3 different studies that have been previously completed, looking at the change in lymphocyte counts. These are total lymphocyte counts and not CD4 counts, but comparing people who got, various standard of care regimens. So this one on the left here is a prevention study where people were getting TDF-FTC versus Islatravir, and you can see that, there aren't really changes so much in people getting the TDF-FTC, but there are big dips in the other folks. And then people who are getting Islatravir Q weekly for treatment, and then people getting the smaller daily dose. These are just some pictures showing, again, kind of this divergence between people who are getting 2 different doses of Islatravir for HIV prevention versus placebo, and then again for PrEP, just the big dive in lymphocyte counts, but that it does return to normal once people start taking open label PrEP. It comes back up to normal. And then here's a switch study of people who are getting Islatravir as a switch regimen or part of a switch regimen in the weekly doses compared to standard of care ART. So what does this mean for the future of Islatravir development? So they found that Islatravir results in dose-dependent decreases in total lymphocyte count and CD4 count. The effect was stronger in people who received the Q monthly and the Q weekly doses in comparison to the daily dose. So as of this point in time, Islatravir monthly dosing for PrEP has been discontinued indefinitely, especially because these are people without immune dysfunction, and it just seems to be too toxic to give as a preventative measure. There is ongoing study and development, which I'll talk a little bit about in the next slides, daily and weekly dosing for HIV treatment, but those are lower doses than these ones that were showing toxicity. They noticed from just a safety standpoint, they didn't see any signal of clinical risk of infections. And then these are the doses that they've changed to. So previously they were using 0.75 milligrams daily for treatment, which is now 0.25 milligrams. And then in the weekly dosing, they've gone from 20 milligrams to 2 milligrams. And then they're looking at the intracellular levels of the active drug to show that it's both sufficient for treating HIV and doesn't cause lymphotoxicity. Okay, so these are the last 2 studies that I'll present. I'm going to put them up on the same slides and present them in parallel. They were presented by 2 different authors. These are both Merck-funded studies, and they're kind of exactly parallel design. So I think it's just easy to put them right next to each other. So Jean-Michel Molina and Andrew Mills both presented these 2 oral abstracts. These studies are both switch studies funded by Merck, multinational studies that are looking at people going from their standard of care ART onto doravirine plus Islatravir in a daily formulation. So Merck 017 is 15 countries with representation really throughout the entire globe. Is an open label study comparing people's baseline ART regimen versus a randomized switch to doravirine Islatravir. And then the second study, 018, is people who are coming into the study already being on BF-TAF or bictegravir, FTC, and tenofovir lefenamide. So I'll say BF-TAF, which we also know as Biktarvy, but I'll use the generic name. And so switching in a randomized fashion to doravirine Islatravir. So again, both these studies have fairly similar design. The criteria for coming into the study was being 18 years of age or older, virologically suppressed. For the study, the comparator was BF-TAF. People had to be on BF-TAF and suppressed for at least 3 months. On the other study that was just looked at what they call baseline ART, people could be on any 3-drug regimen that was anchored in either an NNRTI, a PI, or an INSTI, and this is just the breakdown of who actually enrolled on those regimens. And they were randomized 1-to-1 in both studies to switch. And then for the baseline ART study, everybody who remained on their baseline ART got to take open label doravirine Islatravir starting after 1 year. And then on the other study, they continued on the BF-TAF regimen and didn't switch back on that one. I should also mention, so people had to have no known resistance to doravirine or relevant NNRTI mutations, and then could not have active hepatitis B infection, since the study regimen wouldn't be covering hepatitis B. Both of these studies you can see have well over 600 patients in them. So here's the FDA snapshot of week 48. So we can see on the baseline ART study, nobody became viremic in the study arm receiving doravirine and Islatravir compared to 5 people who remained on usual treatment. As reported in the FDA snapshot, they always importantly show people for whom there was no data. So you can see there's about an equivalent number of people with no data. So overall, a 95% suppression rate that was not different in both arms. And then again, for the doravirine and Islatravir versus BF-TAF study, we have 2 people who became viremic in the doravirine and Islatravir arm, 1 person who became viremic in the BF-TAF arm, and about an equivalent number with missing data for a 94% suppression rate in both arms with no difference. I put down below CD4 changes. So as we were just talking about the impact on lymphocytes, so we're calling this is using that higher dose Islatravir that's no longer being used. But as this is now a completed study, so we can see that there's overall a 65-point difference in CD4 counts between the 2 arms, in which it went up in people receiving their baseline ART and went down a little bit in people receiving doravirine and Islatravir, and same thing for the other study. So the conclusions from these 2 studies together is that doravirine and Islatravir was non-inferior to either baseline ART or BF-TAF regimens. They were similarly tolerated. Sort of interesting, in only one of these studies did people have more study-related mild adverse events in the switch study, but they were all mild, sort of like headache, insomnia, nausea, and weight gain, and less than 2% difference between the study arms. And it's important to just always think about that when people do open-label switch studies, they always report more symptoms in the arm that switches, because they came in on a regimen that they were tolerating and were on that regimen because they were tolerating it. And then now they're starting a new regimen and they know they're starting something new because they're not blinded. So it's a little bit of a grain of salt, but good to know that it was pretty well tolerated. They did recapitulate these previously described lymphocyte drops. And then there are now 2 more parallel phase 3 studies that are ongoing with this new 3-fold decreased dose of Islatravir to try to minimize the toxicity effects and then hopefully show that it still remains its good viral efficacy. Okay, so super quick trip through, and this is mostly, I think, to just provide these in the slide deck as reference since we don't have a lot of time left, but some ACTG studies. So mostly some updates from Reprieve, a lot about cardiovascular health and metabolic composition in people on ART for a long term. And then a bunch of COVID studies. Most of these came out of the ACTIV-2 platform, and I starred the one that I got to present, but several randomized trials that came out of ACTIV-2. So that is it for me.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.